A very good evening to everybody. I welcome you all to the fifth day of our webinar, Everything About Fertility. Today's topic is Understanding Basics of IVF. IVF is the short form of in vitro fertilization, which is a medical procedure of fusing the sperm and ovum in a lab in a petri dish or test tube for formation of an embryo. Hence, commonly it's also known as test tube baby. Today we have with us Dr. Yamini Agarwal, fertility consultant from Nova IVF Fertility, Siliguri. She will discuss the nitty-gritty about IVF today, how the procedure works, and what are the steps involved. Dr. Yamini did her MBBS from Sri Siddharth Medical College, Tumkur, followed by MD from Sri Devraj URS Medical College, Kolar. She was associated with a number of medical and fertility institutes and has more than 8 years of experience in the field of obs and gyne and fertility as well. So without further ado, I would like Dr. Yamini to start our session today. Ma'am, over to you.
Good evening, everyone. Thank you for your kind introduction. So today I'm going to speak about understanding the basic steps of IVF and ICSI. So what is important in this topic is that whenever we counsel patients regarding the need for IVF, couples, whenever we tell the couples that you need IVF, we can see there are so many apprehensions in their mind. They have so many questions related to it as to what will be the procedure like, or how many days it will take, or how many injections they have to take, and whether it will be painful or not, or whether the baby will be congenitally abnormal or not. So choosing this topic, I hope I'll be able to help you out with all these doubts as much as possible. Next slide, please. Next slide. Next slide, please. Yeah. So coming to my first slide. So before I explain you something about IVF, I would like to tell you first about what is the process of natural fertility. So natural fertility, what happens? The female partner ovulates once in a month with one egg every month. And once that egg goes into the fallopian tube, that time when husband-wife comes in contact with each other, the sperms of the husband, they swim up to the tube to form an embryo. This is the natural process what I'm talking about. So this embryo from the tubes, they go into the uterus and they form a baby ultimately. So what we are doing in IVF here is the same process, but we are doing it outside the body. Like the fertilization, when it's happening inside the fallopian tube normally, we are doing it in the lab. That is why it is known as in vitro fertilization. And one more thing is that we are doing it in an exaggerated way. That means every month, naturally, when a female ovulates, she ovulates 1 or maximum 2 eggs. But what we are doing in vitro fertilization is that we will make many eggs in her ovaries, and that will be taken out in the lab, and that will be fertilized with the sperm. So this is the process in short of IVF. So coming to this slide, as you can see, the first part is stimulation of the ovaries. Okay, so how do we stimulate the ovaries? Like I said, we do it in an exaggerated way. That is, we stimulate the ovaries by giving injections to the female partner for around 8 to 10 days usually. And there are many eggs which is formed in her ovary. One concern what the patients have is, are these injections painful? Let me tell you one thing, that nowadays we give injections which are subcutaneous, and these are not very painful. These are not a trouble to take also. So first injection you can take in the center itself, and later on you can administer them by yourself even. So once the ovaries get stimulated, that means once the follicles, we get many follicles in the ovaries after taking 8 to 10 injections. Follicles are the fluid-filled cavities which contains eggs. So then we do an ovum pickup procedure, that is the retrieval of eggs and sperms. So once the eggs are retrieved from those ovaries, we collect the husband's sperms and we unite that sperms, we fertilize that sperms with the ovum in the lab. That is the third step, fertilization of the eggs, which happens in the lab. Normally, it happens in the fallopian tubes in a normal natural conception. But this process we are doing it in the lab. So in the lab, when we are fertilizing the eggs with the sperms, after that the embryo is formed, and this embryo from the petri dish, it is either we freeze the embryos or we keep the embryos in the incubator. So once we decide that we are transferring the embryos, we take it out from the incubator, and in the catheter, the embryos are transferred back into the female uterus. And after the embryo transfer procedure, after around 14 days, we do a beta HCG test to know whether the pregnancy has happened or not. So the IVF process is basically in 3 parts. First part is stimulation of the ovaries with injections to get as many number of eggs as many as possible. The second step is after the egg retrieval, that is after the ovum pickup procedure, the fertilization which happens in the lab. And the third most important procedure is the embryo transfer. Next slide, please. Next slide, please. Okay, so what is the aim of stimulation? As I have already told you that first step is to stimulate the ovaries. Okay, so during IVF-ICSI, we stimulate the ovaries of the woman by means of hormonal injections. So usually what happens when one egg develops, there are many other eggs in the ovaries which die off because there is no hormonal support to them. But by giving injections, we are giving them hormonal support so that not only one egg, but many eggs develop in the ovaries. So these mature eggs thereby can be used for fertilization outside the body. So the number of eggs present in a woman's body is fixed. And the number of eggs which can be retrieved in a woman in a cycle depends upon the ovarian reserve. So I would like to tell you that ovarian reserve for every woman is different. Especially the aged women, more than 35 years or more than 40 years, we see that the ovarian reserve is considerably lesser than the young females of less than 30 years. So that is one mistake what the patients do is they compare their treatment with others. So you should never, one thing you should remember, that never compare your response with some other patient's response, because maybe her ovarian reserve is better than you or maybe lesser than you. Maybe with the same dose of injections or maybe with the same number of injections, you have had 10 eggs, whereas the other patient might have had only 5 eggs, or she might have made maybe 15 eggs. So you cannot compare one's body's response and the ovarian reserve with the other partner. Next slide, please. Next slide, please. Okay, so once we have decided that we have to stimulate the ovaries and we are going for IVF, so then we have to choose which protocol should we use. There are numerous protocols which we can use, but what we have chosen is the evidence-based and the safest protocol, which is the antagonist protocol. So what we should do is, on day 1 of your periods, that is the day when you get your periods, you should book an appointment with the doctor. Then on the 2nd or the 3rd day of your period, you have to come to the center and a basic transvaginal scan will be done for you. One more thing is the patients have doubts that I am still bleeding. Can the scan be done on me while I am bleeding? Yes, because it is a very simple procedure and it has to be done on day 2 or day 3 of the cycle for best results. So once we decide that, okay, we are stimulating, transvaginal scan is done on day 2 and day 3. What we see in the scan, we see the ovaries, the uterus, how is the uterus, whether the endometrium has shed completely, whether you have bled properly, or how many follicles are expected from your ovaries. What is that in other words, what is your ovarian reserve? Or how many follicles can we see in your ovaries, so that we get a rough idea as to how many follicles we can expect from you, how many oocytes we can expect from you. So after doing a scan, you may need some hormonal test, blood test, and some pre-IVF investigations to see your fitness. And last but not the least, the semen analysis report has to be there, and semen freezing should be done. Why semen freezing should be done? Even if the semen report is fine, why semen freezing should be done? It should be done because sometimes what happens on the day of ovum pickup, because of the urgency of the procedure, the male partner becomes apprehensive and it's difficult for him to give the semen sample at that time. So if we have a backup, so it will be nice, so that in case he is apprehensive and not able to give the sample, we have a second sample in hand. Next slide, please. So once the scan is done, investigations are done, semen is frozen. So now from day 2 or day 3, the injections begin. So the female partner has to take daily injections for around 8 to 10 days. The dose of the injection is decided depending upon the age, the ovarian reserve, as I have told already, the weight of the patient, and the previous IVF response if she has had any. Doses usually vary from 150 to 450 international units. And as I said, daily injections for 8 to 12 days is taken. So see, this photograph is the photograph of your ovary, how it looks. This black circles, which you can see, the black ones are your follicles, follicles which we see that how many eggs we can, which is expected from your ovaries. Next slide, please. So now you have to take injections for the first around 8 to 12 days. As I said, the injections can be taken subcutaneously and these are not very painful. So first dose can be taken in the clinic itself as per the patient's choice. Then they can self-inject or come to the clinic daily for injections as the choice and convenience. Next slide, please. Next. Yes. So cycle day 2 or 3, once the injection is started. So next visit of the patient should be usually on day 6 of the stimulation. So what will be done after 5 days again? Again, we will do a scan for you and see whether the follicles are growing or not. Like what is your response to the injections? Or you need any dose adjustments, whether to increase the dose or to decrease the dose based on the ultrasound findings. So usually one of the follicle usually grows to up to 14 mm by day 6. And if a dominant follicle is around 14 mm, we have to add one more injection, which is the antagonist injection is added to prevent the premature rupture of the eggs. Again, this injection is also not painful and it can be taken subcutaneously. Next, please. Yes. So after day 6, once the antagonist is added to your protocol, so again the patient has to come on day 8 or day 9. That is after 3 to 4 days. Usually we see that most of the eggs mature by 8 or 9 days. That is, most of the follicles is around 2 to 3 follicles at least is around 17 mm. If we see that 2 to 3 follicles are more than 17 mm and rest of the follicles are around more than 15 mm, then we decide to give the trigger. Now, what is the trigger? The trigger is the last injection which is given in this protocol, and so that the eggs, what we get are the matured and good quality eggs. And after the trigger, after 35 to 36 hours, we do the egg retrieval. So on the day of the trigger, we will decide, depending upon your response, depending upon your hormonal status, whether we will go for fresh transfer or frozen embryo transfer. Now, what is fresh transfer? Fresh transfer is what? That in the same cycle, we are going to create your embryos and transfer it back into your uterus. And what is a frozen embryo transfer? It is like, if we are retrieving the eggs in this cycle, we will create embryos and we will keep it for vitrification. And then later on in the next cycle or after 1 or 2 cycles, we are going to transfer the embryos back into your uterus. So this is the photograph you can see. This is how a stimulated ovary looks like. These black circles, as I already told you, these are the follicles. This black color is the fluid which is there in the follicles, and the eggs are present in this fluid which is there in the follicles. Next slide, please. So as I said, the trigger, why is it given? The third injection, that is only a single injection. Why is it given? So that the eggs mature and we get a better quality of eggs. So there are different types of triggers. One is HCG trigger, one is agonist trigger. Depending upon the situation, we give different types of triggers. So what are the factors which will help us to decide whether we will transfer in this cycle or we will do a frozen embryo transfer? Suppose your ovaries we are stimulating and we get many number of eggs, like suppose 20, 25, and we are scared of a complication of ovarian hyperstimulation. So we give a GnRH agonist trigger to you. So at that time, to prevent the complications, we will decide to transfer in the next cycle, not the fresh transfer, but a frozen embryo transfer. If your hormones are going haywire, like if the progesterone is more than 1.5, or if we have to do additional procedures like PGT or ERA, these are usually done when there is recurrent IVF failures or recurrent abortions, then we go for these kind of advanced procedures. Or if your endometrium is not matching with the ovarian follicles on the day of trigger, if your endometrium is thin or there is any fluid in the endometrium or we see any pathology in the endometrium, because if the endometrium is not good, the embryo has to get implanted in the endometrium. So the soil has to be good before the seed is planted on it. So this is these are the situations when we plan for a frozen embryo transfer. Whereas most of the other situations, we can go for a fresh embryo transfer, that is transferring the embryos in the cycle in which we are retrieving your eggs. Next slide, please. So we have finished the first part, that is stimulation of your ovaries. So now you have come on your day 2, we have done a scan, you have taken injections, the eggs are formed, we have given a trigger. Now once the trigger is given, we have to do the ovum pickup. That is done after 35 to 36 hours after the trigger. So what is the procedure of ovum pickup? Again, the patient has the doubt that whether this procedure is painful. I'll say no, because it is done under anesthesia. See, you can see the procedure. It is done under ultrasound guidance, under anesthesia. So this is the process by which the mature eggs are removed from the ovaries of the patient when the ovary has been stimulated, and is done usually after 35 to 36 hours after the trigger. Next slide, please. Next slide, please. So what is the procedure like? So as you can see in this photograph down, the pink one is the uterus, and a needle is being inserted through the vagina to the follicles, and the follicular fluid under ultrasound guidance is aspirated from the follicles, and it is collected inside a test tube, okay? So which is temperature controlled. So once the test tube, we collect the fluid in the test tube, then this test tube is passed to the lab where the embryologist examines the fluid in the test tube and looks for eggs and sees how many eggs are there or how many mature and good quality eggs are there. So this is the process of oocyte retrieval, that is the ovum pickup. Next slide, please. Next slide, yes. So what are the complications of ovum pickup? So ovum pickup is usually a very simple and straightforward procedure. Usually we don't encounter any complications in this procedure. Sometimes, very rarely, there might be bleeding or injury to the bowel or bladder, or infection or complications of general anesthesia. But usually it doesn't happen because we do a workup of the patient properly before stimulating the ovaries. Next slide, please. So now once your pickup is done, we have done stimulated your ovaries, done your pickup. Now the lab part comes into action. So as I have told you that the fluid is collected, the fluid contains the eggs. Now this fluid is passed on to the lab. Now in the lab, what the embryologist does is she screens the fluid under the microscope and looks for how many eggs are there in that fluid. And we ask the husband to collect the sperms, and then the sperms and eggs are mixed up, that is, they are fertilized in the lab, and the embryo is created. So the embryos, then the embryos are carefully cultured and monitored up to the time, maybe usually day 3 or day 5 days. And if we are doing a fresh embryo transfer, these embryos are transferred back into the womb. Because fertilization, embryo growth, and development are dependent on the lab, it's very important that we make sure that the IVF clinic which we are choosing has a good lab with good technologies, because a lab itself can make or break the success of your cycle. Next slide, please. Next slide, please. Yes. So now you can see the lab, the photo of the lab, how important it is, because the lab has to be temperature controlled. It has to be sterile. The proper light and temperature control should be there in the lab. This one, what you can see is the workstation with the 2 microscopes, where the embryologist works and screens the fluid which is collected, looks for the good quality eggs, fertilizes the eggs with the sperms, and looks for embryo, which embryo is of good quality. Then secondly, what you can see are the incubators, which are also light and temperature controlled, where the embryos are kept after being after the eggs are fertilized. And this is the embryoscope. An embryoscope is a instrument which helps in monitoring the embryos, their growth and development, and helps us to choose the best quality embryos which we can, which will give the patient the maximum chances of giving patient the pregnancy. Next slide, please. Next slide, please. So this is the workflow, what happens in the lab. As I already told you, the ovum screening happens. That is, the fluid is screened to look for good quality ovum. The eggs are usually surrounded by some soft cells which are removed. Then the ICSI, that is the fertilization process, is done. And later on, the fertilization check is done, whether the fertilization has happened or not. And the embryo which is formed is graded, whether it is grade 1, 2, 3, depending upon the quality of the embryo. If we are doing a frozen embryo transfer, we will freeze these embryos by cryopreservation. And later on, when we are planning that, okay, fine, in the next cycle, we will transfer the embryos to the patient's womb, then we will thaw those embryos and we will transfer them. Next slide, please. Next slide, please. Okay, so as you can see, what I have already explained you, so this is the fluid. And these are these black dots are the eggs which are there, and which is surrounded by some cells which are removed before ICSI. Next slide, please. So the same thing, that the cells surrounding the egg should be partially removed before doing ICSI. And this is done with the help of some enzyme which is present in the Petri dish. Next slide, please. Okay, so eggs, like what I told you, that the good quality eggs will give you the maximum chance of pregnancy. So as we can see in these slides, there are 3 types of eggs which are present. So when the fluid is collected and that is examined under the microscope, what the embryologist looks for are the M2 oocytes, which are the best quality oocytes, and that will have the maximum chances to fertilize with the sperms. So there are 3 types. One is germinal vesicle, one is metaphase 1, metaphase 2. But metaphase 1 and germinal vesicles are a little immature oocytes, whereas metaphase 2 are the mature ones and the best ones which we can get. Next slide, please. Next slide, please. So once we find the M2 oocytes, you might have seen that whenever you get the reports, the doctor tells you that yes, we got 12 oocytes, but there were 8 or 9 which were metaphase 2. So those metaphase 2 oocytes are the ones which are the good ones. So next step is, once we get the good quality, that is M2 oocytes, the sperm is collected from the husband, and the sperm preparation is done to remove all the impurities from the sperms. There are different types of, there are different ways in which sperm preparation can be done. Can be swim up method or density gradient method, whatever may be the way, depending upon the sperm quality. So the sperm is prepared by removing all the impurities and immotile sperms in it. And the best sperm is selected for ICSI. Next slide, please. So this is the andrology lab where the semen sperm analysis and preparation is going on. And these are the canisters in which the semen freezing is done. As I told you before, that sometimes we freeze the semen before, so that in case of apprehensions, and if the husband is not able to collect the sperm on the day of pickup, then we can use the frozen semen sample. Next slide, please. So this is the process of ICSI, what is going on. Once the sperm is collected, the egg is there in our hands. We do ICSI, that is the sperms are injected within the eggs under the guidance of a micromanipulator. Next slide. Okay, so this is the photo. The first photograph is of the normal fertilization, which like what I had already told you, that in the lab, once we do ICSI, then we do a fertilization check, that what is whether the eggs and the sperms have fertilized or not. That is done after 16 to 18 hours. This first photograph, which you can see, is a good normal fertilization has occurred in this embryo, whereas the second one is not so good. So as we all know that any embryo contains half the genes of both the parents. So here we can see that both the nucleus of the parents have come together, and it is a good fertilization. Next slide. Okay, so these are the stages of the embryo. Like your doctor tells you that we are transferring day 3 embryos, or we are transferring day 5 embryos. What do they mean? So see, once we take out the egg and the sperm, we fertilize them, how the embryo looks. Like the embryos the cells of the embryo keep dividing every day. So first it becomes 2-cell stage, then it becomes 4-cell stage. Then on day 3, usually it becomes 8-cell stage. Later on, it forms a morula. And later on, a very beautiful blastocyst, which is the day 5 embryo, which has the highest potential of implantation. So when we say that we are transferring day 3 embryos, it somewhat looks like this 8-cell stage, and day 5 embryos looks like this blastocyst. Next slide, please. So we grade the embryos depending upon the quality, upon the look of the embryos. So there are different grades, grade A, grade B, grade C, depending upon the quality, the look, the cells, how they are arranged, whether any fragmentation is there or not, whether how normal the cell is looking, the embryo is looking. According to that, we have to grade the embryos, and grade A are the best quality embryos. Next slide, please. So the final step comes now, that we have done the ovum pickup. In the lab, the embryo has been created. Now we have decided to do the embryo transfer in the same cycle. Okay, so the embryo transfer process is also done under ultrasound guidance, and it is also a very simple procedure which is not painful, but it is very, very important to do this procedure well, because the success of the procedure depends upon how the embryo transfer is done, how well the embryo has been placed inside the uterus. So this ultrasound recording, which you can see, is the process by which the embryo is being transferred inside the uterus through a catheter. Yes, and before doing embryo transfers, after the pickup, if we are doing in a fresh cycle, we will ask you to take some medicines, and usually what happens is initially we used to advise patients to take injections, which were oil-based and were very painful. But nowadays, we don't advise to take injections. Usually vaginal tablets are given, which are not at all troublesome, and we get the same success rate as well. Next slide, please. So embryo transfer. Finally, final and probably the most critical step, as I told you in IVF, it remains the rate limiting step in the success of the procedure. So the success rate of IVF is around 30 to 40%. 40%. So the success rate, the patients who become pregnant is around 30 to 40%. It is a blind procedure which is associated with multiple potentially negative factors such as presence of uterine contractions, presence of mucus, and improper placement of embryos. So while doing embryo transfer, we have to place the embryos in the proper place inside the uterus, and we have to make sure that uterus is not irritated and there is not and all the discharge has to be cleaned from the cervix before doing embryo transfer. Next slide, please. So embryo implantation, which is the final and the most critical step, it depends mainly on the embryo quality, the endometrial receptivity. By endometrial receptivity, I mean that how your endometrium looks like. What we can see in the ultrasound is the endometrial thickness, the pattern of the endometrium, that is whether it is tri-laminar pattern or not, and the blood flow of the endometrium is usually seen. So the embryo quality, the endometrium, and of course the efficiency of the embryo transfer procedure. Next slide, please. So to conclude, despite its apparent simplicity, the technique of embryo transfer is of utmost importance in optimizing the pregnancy rates. That means the other steps are important, but the embryo transfer is also very, very important, the way we do it. Next slide. So these are some photographs which shows you these are the canisters in which we do cryopreservation. Next slide, please. So as we have already seen the journey of the embryo, how it becomes in different cell stages. Some are 4-cell stage, some are 8-cell stage, and then later on, finally, it becomes a blastocyst. Next slide. So what is vitrification? Vitrification is when we are preserving the cells at ultra low temperature without affecting their viability. Next slide. So what, like, there are sometimes we feel that if we are doing a frozen embryo transfer, if we are doing vitrification of the embryos, will the embryos become spoiled or will they have the same efficacy as the fresh ones? Let me tell you that nowadays the cryopreservation process has become so advanced, that is the vitrification, that we can retrieve almost 99% of the embryos in the same state as we have frozen them. So the vitrification will not be the reason of deterioration of the embryo quality. Next slide. Next slide. So these are the advantages of vitrification, which is the very advanced procedure that the embryos are not spoiled and it is a very safe procedure to be done. So that is why the IVF lab is very important, because it has to do the fertilization properly, the vitrification, the incubation, everything has to be done in a proper controlled manner. Next slide. So this is the vitrification kit. So one more thing I wanted to show you are these straws. You can see the straw. So as sometimes we hear that one straw is frozen or there are 2 straws. So usually straw means one straw usually contains 3 embryos. So one straw means 3 embryos, two straw means 6 embryos. So that is the way, that is, these embryos are frozen in straws. So that is why it is said 1 straw, 2 straw, 3 straw. Next slide. So this is the procedure which is showing vitrification. Next slide. Okay, last but not the least, it is the oocyte cryopreservation can also be done. The eggs can also be cryopreserved in certain circumstances when fertility preservation is required. As to we know that nowadays, because of so much of ambitious lifestyle, the females are planning the baby very later on in their life. So maybe when they are aging, but they don't have the intention to become mothers at present, so they can preserve their oocytes for later use. So whenever they want to become pregnant, they can use those oocytes. Sometimes, some reasons may be due to cancer, or when the non-availability of sperms on the day of pickup, or when there is a donor-recipient cycle, we can freeze the oocytes. Next slide, please. So to conclude, the cryopreservation is not only the viability, but also the reproducibility of the human embryos, resulting into pregnancy and live childbirth. And hence the vitrification as well as the warming protocol is very effective. Thank you so much.
Thank you so much, ma'am. I think we'll go to the question answer session.
Yeah.
So we have a question from our patient, Miss S. Kaur. So she's asking that she's having Mullerian agenesis and wants to know that as she has no periods, how it will be examined that when my ovulation occurs.
See, actually this, because you are not having your periods, so we have to do a scan. And on the basis of the scan, we will come to know whether the follicle has formed or it is big or whether corpus luteum is there. So once on the basis of scan, we have to see the follicles and start your stimulation process.
Okay. And both my tubes are blocked. Husband's report is normal. No, this is a different patient. I'm sorry. Vaginal length is 1 centimeter. Is it possible to do a vaginal ultrasound? What should be done for surrogacy? What she meant was, she has written that in my case, how the ovaries are examined.
So vaginal length is 1 centimeter. Sometimes it might be enough for us to do the ovum pickup. Okay. With transvaginal ultrasound. In case if we see it is not possible, then transabdominal ultrasound can also be done. And in very rare cases, in case if we are not able to do the pickup through the vagina, we can even do it through the abdomen.
So we have a different patient now. She's 29 years old, married for 6 years. Both the tubes are blocked. Husband's report is normal. Want to go for IVF. What are my chances of a positive result, and will the chances reduce if I go for IVF after 1 year?
What is her age? Can I know what is her age?
29.
She is 29. Okay. So you are less than 30 years. Age-wise, you are absolutely, I don't think there will be any problem in delaying your cycles for 1 year. You have to undergo IVF because both your tubes are blocked. But the only thing is it is better that you get an AMH test done and an AFC, a scan done to know your AFC, so that you get an idea what is your ovarian reserve. If your ovarian reserve is good right now, definitely you can wait for some more time. In case if your ovarian reserve is already reduced, then I think you should go as soon as possible for IVF.
Ma'am, another question is, how many embryos are transferred in the uterus, and can I go ahead with a single embryo transfer if I want to?
Yes, nowadays the latest trend is doing a single embryo transfer. But when we do a single embryo transfer, usually we do a blastocyst transfer. So it not only depends upon the embryos, but it also depends upon your uterus, your age. So everything matters. If everything is in good position, then we can do a single embryo blastocyst transfer. Otherwise, usually we do 1 or 2 blastocyst transfer or 2 to 3 day 3 embryo transfer.
So we have a next question from Ms. Pooja Joshi. She's asking that her IVF was suggested in the month of April 2020, but due to lockdown, we could not start the process. So now when can we go for the process? once this pandemic situation is over?
See, actually, none of us know when this pandemic situation will get over. So it depends upon your age. Again, it depends upon your age and your duration of married life. So suppose if you are married for long, like, and you're trying for long, maybe 8-10 years, definitely I think you can go for ahead with IVF right now. But in case if your married life is just 1 or 2 years and you are young, your AMH, AFC, everything is in good position, then you might wait for a few more months in the hope that the pandemic gets over.
Okay, so we have one more question from FP. Ms. Shahdat wants to ask that please explain how to improve egg quantity, and her age is 35.
See, actually, as I already said, that the ovarian reserve is already fixed in a woman since the time of birth. So there is no way, once we are aging, the ovaries are also aging, and with every menstrual cycle, the eggs are getting used up. So there is no way we can increase the eggs, whatever we have lost, or we cannot gain back the eggs, whatever we have lost. It is just that we can utilize the eggs which are already present and do the best with them, whatever possible. And definitely you can have some antioxidants, some good nutritious, a good lifestyle, which will help you conceive, which will help, but it will not help in increasing your eggs in the ovaries. The ones which are gone are gone. We have to use the ones which are already present.
Okay, thank you so much, ma'am. It was lovely having you in our webinar today, and thank you so much for such a beautiful enlightenment into this whole subject. I would request our viewers to write their queries to us at allaboutfertility@novaivffertility.com, or you can also get in touch with us through our toll-free number. Tomorrow we shall have Dr. Kriti Prasad from Ranchi, who will be talking to us on intrauterine insemination. Thank you so much, everybody, for joining in. Take care and stay safe.